Nice talking with you, Michael. Good. How are you doing?
I'm doing good.
Where are you doing good?
Right now from home.
Good for you. Are you working?
Sometimes, yeah,
It's,
not on a regular basis.
oh, and where are you doing it in Abbotsford?
No, still VGH.
WGH? Okay, well, and how regular is regular?
Oh, about 2 days a month, it seems these days.
Oh, my goodness. Well, are you enjoying your time off?
Oh, yeah, well, we've had lots of rehab, plus I have to go back and forth to Montreal in quarantine because of my mother. What are you
Oh,
doing outside?
uh, not much. Biking and doing a little bit of skiing.
The same here.
Well, okay, we better get Grand Round started because it's 11:58, and I think our speaker's not here yet.
Yep,
I
yep,
joined in
yeah,
just
Evan
now,
just,
but
Oh, you know what? You're having that gravelly voice again.
here I'm going to change my microphone again. How's this voice today? Is that working okay? Yes or
Yes.
no?
Yeah, yeah.
Is that better?
Very much.
Okay.
very clear.
Yeah, sorry about that. 2 days of this gravelly voice.
It's distinctive anyway. I would recognize it. I guess it's we have 1 minute. Um, will your presentation be the entire hour, or what do you think? You're on mute.
I think it may be that length, yes.
You know what? It's 12 o'clock, and I think we're going to start. Um, Welcome to Grand Rounds. Today our presenter is Dr. Evan Kong, who's the head of physiatry and rehab medicine at Providence. Um, Director at family topic he's going to speak today, discussion today is as on the screen, and that's leveraging the rehabilitation to help quality and provide values. I'm interested as Dr. Funk presented to us yesterday at our quality meeting, and oh, sorry. Did sorry. I'm not. I apologize. I want to welcome everyone to Grand Rounds. Uh, my introduction, unfortunately, was distant from a microphone. Dr. Evan Kwong's the head of physiatry and director at Holy Family Hospital, has a great interest in quality improvement and quality assurance, and going to talk to us today about leveraging rehabilitation to improve health quality and provide value. Evan, thanks.
Great, thank you. I just changed my headphones again. Can you confirm that it is still working as well?
Yeah, it sounds fine.
Great, thank you very much. I know I appreciate this. Excited to talk to you about this and connect afterwards with many of you. So it's very grateful here. We're able to share some air and land and see the sky and the mountains on the unceded territories of the Coast Salish people, still learning about the Squamish, Salish, Musqueam and Tsleil-Waututh peoples. I appreciate this, and hopefully you'll catch some air as well during these challenging times. Actually, I do have to open up a Slido, I just realized, because please do so yourself. I actually did not log in just now, and I will do so. Great apologies about that. I am just going to log in. If you can, please do so as well. I'm just going to put it in here. Can some people confirm it is actually working out okay when you log in, or is it not there right now?
I can see it on the screen. 1 second.
I am sorry about that. I thought I had that on the screen there, but I am trying to get the. Any luck there yet?
Nothing.
It works for me.
I'm sorry?
You have it typed, it's coming up with a type the question.
Oh, is that right?
Yeah.
Oh dear. Okay. I'm sorry about that. Let me just give me 1 second here. You can certainly type in the chat box here in a second. As I'm just trying to log in. Apologies about that.
It says no active polls.
No active polls, it says, hey?
Yeah.
Okay. I'm just trying to get into the login here. Sorry about that. I just need to activate it. That's all I need to do here. Okay, so the grand rounds here, it looks like I have part of it here, but let's make sure that it's on.
I think we're fine now. It looks like your slides are starting.
Okay, good. Are you able to see one of the questions in terms of the poll part?
Yes.
Perfect.
What does health quality mean to you?
Yeah, what does health quality mean to you? Perfect. So once you are able to get in there, I'd appreciate if you could type in some things as I talk here. That's going to be part of the next slide. So at the end of this presentation, hopefully you'll be able to describe some of the frameworks to understand quality and value in terms of rehabilitation. Appreciate how a functional model of care can help understand our patients' goals. Apply one of the frameworks I'll be discussing, the WHO ICF framework, and then have further dialogue with us about supporting the functional care needs. And how we'll go about doing that is talking about health quality, rehabilitation, the frameworks, the functional model, and then the next steps. So yeah, thanks for the patience about that poll. I'd like to see on the live view, I don't see anything so far. Is it because there's no things there? Oh, it looks
The
okay now.
first question is there. What does health quality mean to you?
Yes, it looks like it's okay now. Perfect. I see people are talking about things such as personalized, timely, compassion. Yes, compassion, the things are just rolling in here, I see. So I appreciate that. That's helpful to know. So people are talking about some evidence and some factors that you may hear about in terms of the Institute of Medicine about effectiveness and evidence-based, efficiency, timeliness. That's great. Feedback, that's interesting as well. Feedback, yeah, okay. Stay tuned on that. Hopefully I can still keep it working for the next few questions. There isn't actually a lot there. Still getting used to that platform. Patient value is another one. It all depends. I mean, a lot of the quality assurance work and quality improvement is borrowed from the management and production literature. You might hear things such as fitness for use, one of the key historical figures, Joseph Duran, about quality, or zero defects in terms of manufacturing. That's a little bit different when we talk about healthcare. And then many of you may know about the system of profound knowledge and continuous improvement, quality improvement cycles. But it all relates to leadership and understanding of the goals and outcomes. In Donabedian, about quality, I just highlighted, not going to read this all out, but we talk about processes of care. And there are goals and objectives, very specific ones. and value judgments is important because we are putting a judgment on what are the most important goals and outcomes. And all these things that we call medical care, there's many different aspects of it, dimensions of it, processes, structures, and it's all a reflection of values and goals that we see as a society, but we may see on an individual level, but on a population level as well. And the BC Health Quality Matrix does touch on some of those factors you had talked about, and very similar to the Institute of Medicine about safety, accessibility, effectiveness, equity, efficiency, appropriate, respect. Those things that you had mentioned do fall into these categories. This new health quality matrix does focus on health and wellness at the center and in different areas, such as the promotion of health, but also living with a disability and then transition as well. I'm going to actually look at the next poll here and hopefully that will work. Let me stop this one and start another one here. I have to press the play button here, it looks like. What did your current inpatients, this is actually something I did for the resident for noon rounds as well, but what do your current inpatients present to the hospital for as their chief complaint? So it's interesting to hear from the noon rounds, although less attended there, of course, compared to grand rounds. So I'm curious when patients are admitted here. Yeah. Is that working okay for the next poll? Is it showing up? Great, thank you, it is, looks like it. I see here, and I think you might be able to see, altered level of consciousness and fatigue. So these are some of the symptoms. Let me just check here. Actually, you can actually probably see it when I pop it over here. Anything else there? You got a couple here. I'm sure it's just rolling in there. Here, pain, new CHF, sepsis. Yeah, so a lot of these different diagnoses or symptoms, sorry, that patients present with, and then your job, obviously, you go through your usual. So what I'd like to touch on is a very simplified graph, and something colleagues have, I'm sure physiatry colleagues here have talked about before. Y-axis, X-axis, time, needs. After they come in, hopefully their medical needs are decreased. And simply put, rehab needs as well. I know that it's complicated. There's ups and downs with medical, depending on what their acuity level is. And some may argue that rehab needs are quite high at the beginning, depending on what they presented with. But it's just a simple way of looking at it. We'll reference this a lot. Another second equation I'd like you to see is that rehabilitation is not a destination. You'll see in terms of definitions of rehab, it relates to processes of care. And you already know that some of the patients in the acute care hospital get a lot of rehab support from Allied, etc. So I'd like you to keep those two things in mind. In terms of the topic of the presentation of leveraging rehab, well, what does rehab have to do with quality or value? Are they one and the same? Are they different? Are they interrelated? In terms of the WHO definition, it's a set of measures. So I mentioned the processes and measures that assisted individuals, and those individuals who are experienced or likely experience disability, which was mentioned also at the BC Health Quality Matrix. And the keywords are achieving and maintaining optimum function in interaction with their environments. So there's things here about processes, things here about function, and also interaction with environments, sustainability, maintaining, achieving. Because of my area in stroke rehab, this definition is quite well known as well, and it can apply to many different diagnoses, as you can imagine. So progressive, dynamic, right? So that speaks to the changing processes depending on the prognosis and the response to rehab. Again, goal-oriented, first time you're seeing the word goal here, and enablement, enabling a person, again with impairment, which we'll touch on, and again, optimize. And this one outlines the different domains, right? Physical, cognitive, emotional, communication, social, and functional. I think some of the physiatrists may be on this rounds wow, it only feels like a year ago, but I guess it's a bit more than that now. when we did the GF Strong province-wide or physiatry rounds, where the question of this one was, what does stroke rehab mean to you? And you can see similar words that you saw at the beginning about effectiveness, efficiency. Here you can see things like team-based, function, quality of life. And this is from the physician perspective. So just to get a bit of a background regionally, just to have some context. And of course, you have to talk about COVID during the round sometimes, but there's been some changes during these times in the last year. We have, as you may know, in the region, Holy Family Rehab, GF Strong. We do have an activation unit at UBC, and Lionsgate had some closures of their rehab unit, but they've adapted this direct access rehab team that takes patients to the rehabilitation gym, but not having a dedicated unit. So certainly some challenges and changes, and we appreciate the system level, I think, of either GF supporting us when we need to and vice versa. For those of you who weren't aware, I had this slide yesterday also at the MAC, the specialized rehab. As part of the beds, we do have 30 neuro rehab beds. Most of them are stroke, amputee, and then other dedicated orthopedic rehabilitation beds as well in programs. And for those of you who aren't aware as well, we do see people from many different locations. So like many programs in Providence and elsewhere, it can be provincial at times. So a lot of your referrals, considering we do have stroke and orthopedic and trauma, you can imagine it comes from VGH, but certainly Providence is there with St. Paul's and a bit of MSJ. But of course, there's going to be Sechelt or Powell River, and then of course, Richmond, UBC, and Burnaby, just because some of the Vancouver residents end up being in the Burnaby General Hospital as well. In terms of the actual medical diagnoses or the programs, you could say a lot of it is related to stroke, and then other neurological issues such as spinal cord or post-laminectomies, and then the orthopedic, either recon arthroplasties or trauma or polytrauma, and then amputee in general. Caveat to these data I pulled from our own inpatient admissions database, so it may not be reflective entirely, not really cross-referenced to any discharge abstract database or other databases. One thing is key is that not all diagnoses are created equal, and hopefully you'll get that out of this presentation, or you already know that, because there's going to be functional impairments that are quite different. So not all of my left MCA strokes are similar. They may be walking and not being able to speak very well due to aphasia, or they may be completely bedbound. So it's really dependent on that. And I think that's one key thing that we don't have as a system to understand the burden and care needs as a hospital, as a unit, as a system level, if we only focus on the ICD codes and the actual diagnosis. This is a bit of a snapshot from during the time last year. After the pandemic was called, we had, of course, as you can imagine, lots of discharges, people wanting to go home. Then we had a bit of a time when we were trying to help decant acute care. I'll show you a few cases about that. At one point we come up, we're still functioning. This is now, sorry, I'm just looking at the screen there, in May. And I think it's because we didn't see the repercussions later on because people are still undergoing inpatient rehabilitation here. And the decreases in acute care visits and decreases, which we found out later in stroke or presentations for strokes. Then we saw it later on, like a few weeks later, because that's when we would usually admit later on. And that's why I think we saw some dips, less surgery as well. But I wanted to focus on this part because traditionally we would have referrals and we would see them, and they may have some rehab needs that can be managed in an acute care setting, outpatient level setting, or inpatient level setting at Holy Family or GF, etc. During the decanting process, we were asked to review some patients to help see if we can unload the acute hospital. For the 4 cases that I remember that week, I decided to kind of dive a little bit into their level of function and whatever happened to them. So we've got someone ranged from 66 to 92 here with mainly, it looks like 2 orthopedic type things and 2 very generic general medical deconditioning. Their function was essentially 1 person at that time. The challenges for their cases included a lot with cognitive issues, which is usually one of the largest barriers for many of the cases, even without neurological issues. from a stroke, etc. It can be pre-morbid issues. You can see that they had stayed at St. Paul's at that time already for, not so bad here, but quite a lengthy time. And just looking at their cases at rehabilitation, when at Hollow Family Hospital specifically, we were able to understand their functional trajectory and trying to understand the disposition at that time. And it looks as though, on looking at it, now I wasn't involved in these cases, but looking at it on a system level, that the time to quote ALC means different things in different contexts, was quite short for a couple of them, and then after some rehab, realizing some of the potential at that time. So 1 out of the 4 here did go home, the rest went to long-term care, but you can see how the resources are there, for at least from a length of time in the hospital. And are we able to leverage rehab to understand that, or leverage a functional model of care to understand education aspects, coping ability with a new baseline of function, such that we can move people on, not in the sense of discharge or going home, but understanding their new levels of function and appreciating that there may be some limitations. So we're a bit more used to that maybe in medical knowledge about, is this IV antibiotic going to change things versus a rehab on a functional model. We may have aspirations and goals, but have to understand the prognosis of the diagnosis as well. So I was interested in this a little bit and saying, okay, we never really heard about this patient until decanting. Are there actually other patients? So we rely on a referral process to have consultations to understand the rehab needs. But are there other patients that could benefit from rehab or benefit from more structured approach and allied with the allied team at the acute sites? So I was kind of curious. I presented this yesterday a little bit. This was before, data before. Stroke population, there's been a lot of regional work with that, and we had some projects here locally, so I don't think that there was a lot at that time to understand. We do have a process there. We have patients coming in to rehabilitation from Providence sites. They are coming at a timely way. I know this is variable. I'm not a big fan of quarterly reporting, but certainly this, at least for this reporting, you can see some of the targets there. So what about orthopedic? This was a couple of years ago when I was interested in understanding where are all the orthopedic patients for the reconstruction as well as arthroplasty. And a lot of them do come from St. Paul's. And then of course, UBC, considering the surgical process there, and VGH. In terms of them presenting and then referring and then accepting. For the next data set here, the blue represents more of the time from their acute admission until a referral for rehab. Not necessarily physiatry, I'm not able to capture that part. So at one point, physiatry may or may not have been involved, I'm not sure. But there is a pathway for this more simple orthopedic ones, which does not require that. So this captures just from acute admission to the actual process of referral to Holy Family Rehab itself. And then the acceptance and then actually admission to the site. The blue is quite long for some, so I'm not sure what this is. Is it due to the medical needs? Is it due to some weight-bearing issues? What I'm concerned about would be that there would be potential to provide more rehab, and it's not thought about until maybe, for example, here, I'm just looking at this, 20, 40 days out. So is there a potential to provide the quote, right care, right place, right time? Is it at that site? Is it at another site? What do we need to do to help those patients achieve their goals and try and prevent any other decline if they are in an acute setting longer? If we're looking at the admissions from St. Paul's and MSJ, it spans all of those different programs, specifically at Providence here. So you can imagine, certainly not the same as the acute strokes that are funneled to VGH, but we see them obviously here at our sites from a subacute nature. And of course the orthopedic side. So there is an amount there. These are the ones that are admitted, right? So where else are these other patients? We had talked about case finding before, and I do want to stress that it's not only about getting to a rehab facility. This talk is also about providing people with a functional model of care such that their needs could be met at the acute sites, seeing as patients are quite complex these days, and many of them whom I see are having medical changes to their medical plans, but also have some rehabilitation needs ongoing simultaneously. So thus far, we talked about the health quality matrix. Has to do with a lot of different parameters that you had mentioned, and then also at different time points, whether or not it's living with the illness, living with a chronic illness, or preventative care, or transition to a different stage of life. We talked about the simple equation here. A rehab is not a destination because it is a process of care that helps optimize function. And then this graph here that talks about the medical needs. I do want to touch upon that. I mean, we do have some gaps, as you can imagine, that we have resource issues in acute care. We have rehab needs that patients have. And then we've got those intensive environments that are quite intensive and specialized as well externally at our sites. So it's almost like sometimes I think about, are we trying to treat blood pressure with a 5 milligram ramipril and 50 milligrams? And what's all that in between? All the in between those rehab needs that the patient has as they're recovering medically. And we hear that from the patients, and I'll show that as well in terms of their goals, because so far you've only heard kind of the physician voice in some of these areas. And again, related to that function and quality of life that was mentioned in the previous rounds. And then one more thing about the fact that not all diagnoses are created equal, and that the functional impairments are so important to understand what the needs are for those patients specifically. So the care continuum, rehab medicine is involved in different areas, and it could be preventative or promotion of health and prehab or pre-surgical, certainly non-surgical in terms of pharmacological or interventional treatments. Acute care, I think that there is a growing need for that, considering who we see, and it's never that black and white in terms of where they may fall. They have simultaneous needs. And we know about the post-acute care or post-acute care rehabilitation, rather. And then, of course, there's the community care needs, I believe, in terms of sustainability. There's lots of room to grow there. And long-term care, we certainly have rehab docs visiting there. And certain people have a bit of longer-term needs, and occasionally people make some improvements later on. In terms of the quality of care related to rehab medicine itself, this is another discussion. This is actually a 20-year-old article about a need to understand the rehab goals and processes. I need to look at criteria and standards, but the standards are due to or come from evidence base, the knowledge base of rehab medicine, and also guiding principles, guidelines, practice guidelines. But specifically, I wanted to highlight the goals of rehabilitation. But where do we place all of this? There's a lot of discussion about this, but how do we structure it to understand it a bit more? It's easy to say about functional improvements and wanting to know all of those details, but how do we know when we've achieved it, and what are we actually measuring? So some paradigms to consider in terms of the theoretical basis of a framework to choose. It depends on what your belief system and what the theories and what the society believes in. If we talk about constructivism in terms of just piecing together a framework about what we think quality means, what we think function means, or what we think rehabilitation means, there's many different perspectives. If we think about the population who we serve, it's a lot about the critical lens or the critical disability lens in terms of advocating for accessibility due to their disabilities. So we only know this through understanding the social structures, previous history, these power dynamics, especially when you're disabled and you're quite vulnerable when you present for acute care management or rehabilitation management. And having said that, we do know about the structured process outcomes model from Donabedian, but it is quite complex still in that regard. They are interrelated, and I presented this a bit when we talked about value. An article about stroke rehab talked about how the process is only valid if it's linked to a valid outcome as well. Right? So why are we doing that is because we want to be able to achieve the outcomes. Some of the literature also shows that it doesn't matter structure-wise. You might have the best personnel, the best structure, the best equipment, and it doesn't actually help you achieve the outcomes because everything is still interrelated. And they must be related directly to the process of care, and they must be able to be changed. in rehab and in longer term types of understanding of outcomes, I think it's challenging because there's so many different factors that you'll see when we talk about the WHO ICF framework. And that's this one here, back in 2002. I'll just take you through this. The physiatrists are familiar with it, and some of you may be, depending on what you've been exposed to before. But you know, you're familiar with ICD codes, but again, it's a classification of systems, classification system developed by WHO. It's actually over 14,000 items actually. So the practicality of it still is being researched to this day with different types of models. But this is more of a unified and a standardized language to understand health and health-related states. I will take you through this a bit here. So we have, actually, I'll back it up here. We have the health condition. So be it the, like you had mentioned, presentation for the symptoms, but then you've diagnosed with exacerbation of CHF from a specific issue, or a fracture or a stroke. And in terms of the functions, that's what we focus on, the physiological functions, certainly, right? What parameters we can change, we can modify, what interventions can we do, what medications can we adjust. And then the actual structures, for example, in terms of what can be, quote, fixed, what is able to be managed from a medical or surgical perspective. I think we're fairly used to that. What we are always trying to achieve is because the individual has some activity needs and some participation needs. Because they came in, were they short of breath because they were just short of breath, or were they short of breath because they couldn't get up the stairs and they found out that they were short of breath? So all of these different stories that you already are quite experts at, but this is what patients would be telling us for their goals later on as they're recovering. Like I mentioned, there's over 14,000 items there, and it classifies in different systems. So like I mentioned before, we've got the ICD codes of, let's say, stroke or brain injury, but yet there are many different parameters. And we may document that, and now we have Cerner and document those things in a paragraph or basically a non-discrete format. So it's difficult to retrieve and understand what all of those patients look like from a functional perspective. I'm going to put in the other poll here again, and I'm going to back it up here. Stop that one, sorry about that. And then this next one is thinking of one of your current inpatients. What are the top 3 plans for their care? So I'm just adjusting it because of the nice sunshine here. So thinking of one of your current inpatients, what are the top 3 plans for their care? Oh, I don't know why is it doing this? Sorry about that. I was pressing the space bar, so it was deleting everything here. Okay. So pain control is one of them. That's great. Can't move without pain control. And other aspects. I'll wait a little bit here because it does speak to some of the body structure part of the framework that we're used to. I'm going to slide it over here so you can see it. Okay. Anything else that you are able to share? Pain control and, management of sepsis. Bowel protocol. I'm glad you mentioned that. I remember one of the patients talking to me about that. It sounds very basic, but these are the basic activities that they need to do, and unfortunately sometimes it's left kind of unnoticed for their needs. Feeding improvement in ADLs, deconditioning, reviewing the home situation, so that touches on the environment. Sleep log, sorry, I didn't see that. It popped over there. Maybe it's because how the fields are organized. Oral care, sleep log, That's great. Yeah, thanks. I'm going to move that aside here for a second. It's still open if you want to put things in there. So, I mean, I'm just referencing this again because there's a lot of those comments. Where did it go, those comments? Let me look at it again there. About the functional needs. And that speaks to the awareness of their rehab needs at the same time as their medical management of sepsis and pain control. Going back to this in terms of those activities, you had touched upon the ADLs, mobility, feeding. Of course, here, these are kind of older language. We talk about these domestic life, civic life, but these are the aspects in terms of activities and participation. They're kind of grouped together, not necessarily distinct. And when we talk about the limitations, we talk about the difficulties that they have in executing those tasks and involvement in those life situations. So I think you've already touched on this a little bit already, but I think for this one here, it's more about a little checklist for the next one, if you have that poll open. And what do your current inpatients have in terms of activity limitations? I'm curious, actually. Currently, from the ones I'm seeing in acute care, there's one with quite the amount of myoclonus after an anoxic injury, and he can't do much at all right now in terms of even mobilizing, sitting, feeding, etc. There's other one wheelchair bound, but improving. His goals are to be able to feed. The ones that already came, it was more stroke related, so the typical ones about being able to walk, etc. Any ones else? Let me just see who else that we have here. Taking a look. Not sure if things are in there. Is it actually showing up okay there? Yeah, I think so. So walking, I have one there. Sitting up even. Bowel continence and bladder continence, we have kind of the differences there. Walking comes up. It's very interesting, right? There's the goals that people have when they're coming in. I think I have a little bit of a slide there later to show that, but you'll see when you hear them or the What Matters to You campaign or how you approach goal setting, people do talk about, I want to be able to walk out of here, right? So that's this one here about walking. And there are, you can't see it on the screen here, but down below it does have some things about hygiene and washing, eating and dressing. Yeah. So do we have a full understanding of that? I would challenge us as a system. If we were to say out of 300 patients, how many are not able to walk and have walking as a goal right now? I think we'd be hard pressed to say that specifically. But if we were to say how many are on cephalexin or how many are getting pain control or how many on DVT prophylaxis, like we can talk about those things as discrete data elements. But from a functional point of view, we don't have that yet. And I think having that, we'll have a better idea of the burden of care and needs and also the resources that we need to actually move people to provide them those values of their goals. These ones are a little bit more challenging. And I'm sure you've experienced this as well. All the environmental challenges, the personal factors that impact the disposition. And this happens in rehab, this happens in the acute care sites. These ones don't actually have in the ICF actual categories in the same way. It's quite cultural, contextual, very specific to different societies as well. I'm going to open up one more, I think. Hopefully I'm not tiring you too many for these things. But one of the last ones here is about that. I'm kind of curious. I do certainly see housing challenges, different pre-admission family dynamics, different challenges with the actual environment itself. And this is despite them being there actually prior to it. So there's always that challenge of understanding their previous level of function and how they were even coping to begin with. Acute medical event puts them through a hospital stay, but those factors were quite there already. And is it the straw at that time that broke everything? Like what was it? And now we are trying to manage not only the acute, subacute issues, but also very long-standing issues that may happen or may have happened for quite a long time. So thanks. I see people talking about some of the things that we do see as well. Either a substance use, can't care for themselves, mental health, services at home, family or support networks, stairs at home, that we see that quite a lot. We have people from SROs and there's no stairs or the elevator's not working. I was talking about a case a few weeks ago about a successful one. I remember coming to Holy Family and Addictions, but ended up, this is rare, like ending up being at Cooper Assisted Living and off addictions. It was a good story, but how do we as a system improve all of this? Homelessness, so there's a couple I'm thinking of already right now that pops up in my head. So you all have seen this, and this is very common, not just in rehab, but in acute care sites. So this is larger than rehab, certainly, right? But it certainly looks at those factors if you think about a framework. And if we are able to categorize all of this, we can actually have a better idea of advocating and directing resources in a different way. Here you've got cognition. Yes, absolutely. That is one large factor. And we have a lot of people who have fairly good mobility and care needs, fairly good mobility and independence in their care needs, but the cognitive factors, and especially if they're living alone, right? Living in a van, refusing post-discharge support, I often see that. It's interesting, if it's minimal, it's interesting how resilient some people are after I follow up with them in an outpatient setting. Optimizing equipment, or even when we do, after you follow up after a month or two, you find out that it's not really being used at all, right? So a lot of the challenges there. Appreciate that. That is a good list. Hopefully I can still save all of that for the future. So I mentioned there's like over 14,000 elements in there, right? So there were some goals of developing these ICF core sets in the past, and it depends on which nation, which country, continent you are in terms of applying these things. Not quite applied as much in North America, but I think there's potential to look at this. How do we do this practically? And this one here outlines specifically body functions and specific codes. I know you must be tired of ICD-9 and 10 codes, but they're also ICF codes. We have a lot of that information here. Just like after discharge, there may be a coding team to understand, all of the diagnoses. If we had something like that, we might be able to see for all the 100 strokes, how many of them had, you can see here, perceptual issues. That's actually another big challenge that we see, that limit their independence, attention, memory functions, very specific. Maybe we don't have to drill down to the details for a non-research related kind of clinical need. Maybe it's more of these larger categories that we need to do, but happy to have further discussions on how to do this easily. The quality of care in rehab medicine, again, I mentioned the goals of rehab. So we haven't brought really in the patient voice in this so far. But in the next slide, just a bit of a poll of the roster of people I have so far. And I put this slide here as well because of the previous value-based healthcare workshops and the discussions that have been made about the outcomes that matter to patients themselves, whether or not it's through patient-reported outcome measures or actual patient-reported goals. Of course, there can be quite long-term goals and short-term goals, and there can be things that can be realistically achieved in acute care or rehab. These are things that some of the patients have told me. You may have heard it yourself as well, right? I don't want to be a burden to my family. That's a bit of a challenging one to understand and tease out, right? This is more kind of an aspirational or general statement. There may be very specific things like I want to be able to play the guitar. That may be one of their passions. I want to be able to go back to the restaurant and be with my friends. A lot of it has to do with improvement, control. You've seen the discussions in terms of physician point of view about bile bladder. Some of them do talk about that. Stairs, and as you can imagine, some of the challenges that you had mentioned already. So from the patient perspective, after they're trying to cope with this new illness, there are a lot of different goals. And if we're talking about providing value, all this discussion about quality and value, we hear a lot of it about function. So even in the post-COVID clinic, people talk about, I can't exercise, I cannot think, I cannot do my work. And these aren't necessarily now things that we know for sure because we're still learning about it. But even for the ones that we do know about, for stroke, for brain injury, we do have ideas about the theoretical basis of recovery, right? And then their actual goals, the prognosis, and how do we fit that into manage a rehab plan to achieve that? And that is what would provide value, right? This is after the medical diagnosis is made, you've done the treatments, but now what? I can't go home. I can't function. I'm still in hospital, or maybe I'm in the community. And that's what I want to help kind of discuss in the future. If we look at what's actually done and kind of see it a bit on paper, this is something that was kind of coined and published. I think it might be later on more of a trademark type of a thing, but it's challenging because this is what people do. So you can imagine this looks very similar to like a PDSA cycle, right? You're identifying problems and needs and goals of the patient, relating it to some of the barriers and limiting factors due to the structural or diagnosis. And then what can we measure? Is it going to be their balance? Is it going to be their walking distance, their ability for very specific outcome scores? And then you plan and implement each week and assess the effects, and you keep going. Right? So this is essentially what is done in rehabilitation. And someone even kind of took it one step further and combined it with the WHO ICF. And a bit tiny, sorry for if you have a smaller screen here, but essentially for those in rehab are quite familiar with the multidisciplinary nature here, the team meetings that would happen, and then the duties for each of the disciplines, and then another team meeting. And again, that rehab cycle of looking at from the patient's perspective and their goals, our perspective in terms of barriers, how do we do appropriate goal setting, and what are the targets we're trying to achieve? And then each people's tasked to start achieving them on a short-term basis and then a long-term basis. What's different and a bit more complex in this study was trying to map all of this out. There are very specific mapping rules that can be done with the ICF to look at it, because it's difficult. Of course, you can imagine clinically, you're not going to be able to map B108 to something. You're describing the different functional impairments rather than doing coding, right? So again, data entry is a burden. For the residents on the call, you may be aware of the DeLisa textbook for physiatry, and there is a figure in there, and I believe maybe one of the first chapters, but there is the short-term goal and long-term goal, the patient's perspective in terms of the ICF framework, the health professional's perspective, and then those contextual factors. Take it one step further in that study, and they had mapped out a very complex diagram of functional impairments and goals. So you can imagine this could be very difficult. In this case, sorry, it's a bit small as well. And also the paper is quite fuzzy in that figure, actually. It has things like reduced mobility and a conjunct spasticity for this particular patient. I believe pain control is there, muscle stiffness. But then there's actually things that the patient would actually say, my bladder and bowel exercises exhaust me. I have had pressure sores. So there's both perspectives there. And then there's an understanding how all of those are linked to see what the treatment plans are. We don't use something like that at Holy Family specifically. We use the CCAT tool, or Collaborative Communication Action Tool. It's external to Cerner. We've been able to continue using this throughout this time because it does help facilitate our team rounds. And you can see let's say the current status, their short-term goals from patient language, friendly language, the goals by discharge, or longer-term goals, apologies. And then the action issues, for this one, not too many. There's sometimes a lot of kind of medical ones kind of coming up here. And there's different things about the ADLs, IDLs, psychosocial passes, discharge planning, and how do we go about it in a systematic way, estimated date of discharge, to kind of help plan out the course early on. This actually generates a bedside care plan for the bedside for the nurses, because it's not going to be only about the therapy time and the allied time. It's going to be about their management at the bedside with the nursing staff, and even self-management at times, depending on what happens. So this actually allows people to have a safe way of doing all the functional tasks. And then the rehab goals in terms of further discussion from the patient's expectations for the short-term and longer-term goals, and their estimated date of discharge. And are we actually on track every week when we're trying to understand their trajectory? Yeah. One of the other frameworks, so we've talked about the WHO ICF framework, which is quite detailed, and it's a categorization of function. And we talked about this rehab cycle, which actually happens on a clinical level, but someone's been able to research it on a more of a detailed research level. There's another framework you can look at here called the post-acute care framework, but I think it can apply to acute care in different settings as well. You can see is actually a combination of what we already talked about, the structure, the processes, and outcomes. And then there's something that they detail in this article about the process outcomes interface, because there's going to be a lot of changes happening from the patient's perspective. From the structure you'll probably be used to, do we have the facilities? Do we have the equipment? What's our resources? We don't have enough X, Y, or Z. And what's the actual organizational structure there? Early on, we talked about what quality means to you. Someone mentioned evidence-based guidelines. Are we actually doing all of this? But there's also individualization happening. For rehab specifically, parameters around the amount and timing, and then team-based coordination of care in terms of interprofessional processes outlined here. The patient in the middle, and then also now you see the WHO ICF outlined here in terms of what we talked about for those categories. And the outcomes that they put for this framework was about kind of the immediate ones. And those are related a little bit more to the processes in rehabilitation. And then the larger outcomes, and as you go farther with time, all of those other environmental, psychosocial, pre-morbid, all those factors, housing, those things dictate a bit more about sustainability, right? So it's not going to be all directly related. So we have to understand what is actually within our control, I think, versus what is related to the community as a whole, or society as a whole, rather. So having said all of this, we talked a lot about the kind of different kind of frameworks, talked about how rehab is not a destination, it's more about a process of improving function, and how the medical needs, as they come down, there's going to be more rehab needs. We have different dosing of rehab currently, and there's certain patients that require a lot of simultaneous care. We talked about the diagnoses, how there needs to be a functional look at things. Otherwise, we don't know how much we need to give patients for their goals. Oh, sorry, I see something here. Someone was, okay, that was for before. Apologies there. And then value in terms of what's been discussed in the last year about outcomes that matter to patients. And a lot of the patients will talk about more functional needs. So we have to understand where those functional needs fit in our system of improvement. Is it in acute care? Is it simultaneously? Is it post-acute care? And then what are the needs in the different settings from the continuum that we talked about? So what are the next steps? Well, our Division of Physiatry at Providence did do some facilitative work recently, and looking forward to further collaboration and stakeholder engagement about interdivisional, interdepartmental needs and plans. Our purpose is to optimize care and function, not only for people, but also populations. And as you saw with the framework, it's for those who are experiencing impairments, disabilities, and diseases. At the same time, trying to improve, didn't talk about today in terms of research education, but improve quality clinical care. And I'd be happy to discuss further with anyone. It'd be really good to see from an organizational perspective, how do we provide functional value in acute care? We see many people, like I mentioned before, and you're aware of many cases that require that, and these are their goals. And how do we do that while they still have some medical needs? So I'd love to hear more from the different divisions, departments, units, programs, because during that phase when we were looking at cases to come in, there's some that we weren't even aware about because we rely on a more of a referral source. So I think there's an opportunity to do some in-reaching to understand how your patients could benefit from this functional model of care. It's been very fortunate, the CNS, Dr. Bina Parapelli and Dr. Charles Tai, and the multidisciplinary team had been doing these weekly neuro rounds. They're initially stroke rounds. So reaching in to understand some of those patients, have had talks with the Allied about ICU, high acuity, about some of these needs as well in critical care. So there's lots of different avenues we can go about the diagnosis to look at, the functional impairments, and how we can support them in acute care itself. And of course, if we need to do more specialized rehab. So with that, I leave my email here. You know how to reach me if you'd like to contact and have further dialogue in the future. But also, obviously, open to questions as well. There's only one more poll question there in terms of what would you have liked to learn more about today. I'd happy to hear from you about that as well.
So thanks, Evan. Before I open it up to others for questions, I wanted your comment, because you're basically outlining quality care at a systems level, at an individual level, and different components of the healthcare system. Especially in this time, but not specifically related to this time. If I were looking for elements of quality, the quality that I would want to see predominant, not subservient to the other forms of quality, to be reassured, is safety. And so with that lens, how would you reorganize rehab or physiatry or all of the systems of medical care for all of these different groups? Because many of the issues were brought up seem to hinge, at least maybe not using those words, but that's how I would interpret them. So I'd be interested in your comments.
I love that question. Yeah, I didn't touch on very specific safety needs here, but medical touches on that only in an indirect way. Many ways of going about that, I think. In terms of safety, we do need that medical expertise and knowledge. And in acute care setting, I would say on kind of individual unit level or maybe patient level, are we absolutely sure that this patient does not require the medical needs already? Because as you can imagine, let's say a patient, I'm just thinking about some patients here already. Unfortunately, one did not make it, and we were talking about rehab plans because there was a really bad infective endocarditis, essentially, and with some septic emboli to the brain. And there's some rehab needs, but are we absolutely sure that this patient's safe, and what's their prognosis for their medical diagnosis? And that will impact it. It's not just about putting the patient into a rehab setting. It's about, wait, let's make sure that this patient's safe from the medical point of view. So with that, that's more the acute care setting. And in rehab, I would say externally, it's about accessing, and that's why we were trying to improve yesterday at the MAC about improving access to medical specialty care as well, because there are certain populations that end up going to emerge as well, and we need to understand that in rehab, things can change as well from a medical perspective. So do we have a way to prevent that? We have to look at that, I think. In terms of things that you're quite familiar with, people going in for an unrecognized GI bleed, people going back into acute care for a urosepsis, right? So these kind of basic parameters I think we can look at. And then there's the ones that we might be more familiar in acute care about falls, but in rehab, falls is a bit of a challenge because we are trying to improve their independence at the same time. So there's a different risk tolerance as well. So we can take a look at the basic nursing adverse events of pressure ulcers and UTIs and things that we're quite familiar with and understand which ones affect people in a rehab hospital setting. But in the acute care setting, I think it's the safety. Can their needs be met here? What else is needed? Because often we end up seeing that as well. And that's why that whole medical stability piece is so important. No, I like that question. That's great.
I just follow up to that question, and I think Andrea has a question, but the follow-up is that I don't think it's actually acute care. I think it's safety wherever you are. If I were reassured that I'm going to do my rehab and I'm in the safest possible environment, that's a very different attitude that I carry and different confidence than if it's just efficient or there are those other parameters wouldn't reassure me. So that's just my comment. So I think Andrea had a...
yeah, that's great. Yeah, Andrew has a comment. Do you feel physiotherapy in acute care is adequate? Would some patients in acute care benefit from more physio than what is currently available? I would say my reflexive action is yes. Why do I say that? This is only from my impression, but of course, if we want to be very data informed, I think we should look into that to better understand that. Why do I say that? When I see people in acute care, some of them have more potential at that time. And what we're trying to do is trying to get them to do more, but they may have basically less resources. So I know it's a regional challenge for resourcing, but once we understand what people's functional needs are, I would agree. And I'd be happy to talk with more people about how to help this process going forward. Yeah. There's actually one question in that poll about how can we consult you to refer patients? How does this change between hospitals? I can certainly resend out a memo of how to do that. That's a process. There's a central fax and there's also the on-call type of pager as well. Yeah.
Okay, thank you very much. I was privileged to hear the presentation to the MAC yesterday, where you were talking about physiatry, and this is just a continuation. So for my colleagues at the MAC, unfortunately they only saw half, and I get to see the complete picture. So thank you, Evan.
Okay, thank you so much.
And in next week's Grand Rounds, following along this theme, and Evan's already mentioned that Dr. Charles Ty, who's interested in stroke and does neurology, is going to be presenting on stroke in this setting. So please join us. Thanks very much, everybody.